Hello and a very warm welcome to all of you to the Doc Plexus Global Diabetes Summit of 2021. We will be hosting a 3-day clinical discourse with eminent doctors of the field of diabetology and endocrinology. So I, on behalf of Doc Plexus team, would like to take this opportunity to thank our community of doctors for being a part of our 8-year celebration held recently. We all know that currently India has 77 million people affected with diabetes, which makes it the second most affected country in the world after China. And the International Diabetes Federation has projected this number to grow to 134 million by 2045. Out of these 77 million diabetic patients, 68% are being treated with oral hypoglycemic agents, 25% are being dependent on insulin, and 7% being treated with injectable GLP-1. According to a study published in the Indian Journal of Endocrinology and Metabolism, it is estimated that India is the home to about 97,700 children with type 1 diabetes mellitus. So, with the increasing prevalence of diabetes and a higher incidence of complications associated with diabetes, it is imperative to update and apprise our clinicians around the burning topics of diabetes, and we aim to achieve the same through these 3 days of Global Diabetes Summit of 2021. For day one, we would be addressing the current guidelines of diabetes, practical use, and key opinions. For day two, we will be having an experts roundtable discussion with renowned diabetologists and endocrinologists as a part of the panel to discuss the latest developments in the treatment of diabetes. Day three, we would be presenting to you a one-credit CME webinar on trend talks on diabetes today and beyond. Please note that today is the last day to register for the CME session to earn the credit point. So please check the link in the description box below to register. So without further ado, let's begin the 3-day science-driven discourse. Now coming to today's session, we have with us two eminent panelists who are going to enlighten us with the current guidelines in the treatment of diabetes. Please welcome Dr. Sanjay Kalra and Dr. Joel Tilak Singh. This session will be moderated by Dr. M. Nithin Reddy, who is a consultant endocrinologist at AIG Hospitals in Hyderabad. Over to you, Dr. Nithin.
Good evening, everybody. I'm Dr. Nithin. I'm a consultant endocrinologist at AIG Hospital, Hyderabad, and it's my proud privilege to be part of this program, sharing along with the eminent people in the field of endocrinology. At first, Dr. Sanjay Kalra, who is an eminent endocrinologist practicing at Karnal in Bharti Hospital, is an avid researcher and a clinician. He is the immediate past president of the Endocrine Society of India. He is also the current vice president of South Asian Federation of Endocrine Societies, and he is also an education editor as well as deputy chair, advocacy and partnership working group at the International Society of Endocrinology. He serves as an associate editor for diabetic medicine, and he, along with all the above mentioned responsibilities, also works to spread the endocrine and diabetes awareness across the world. Sir, Dr. Kalra, I would request you to please go ahead with the presentation.
Good day, friends, and welcome to this interactive discussion that we are holding on the World Diabetes Day. The theme of this year's World Diabetes Day is access to care. If not now, then when? Let's paraphrase this just a little bit. Access to diabetes care, of course, includes the fact that we need tablets, we need injections, we need diagnostic and monitoring devices. They should be available, they should be affordable, they should be appropriate. But what will all these supplies do if there are no qualified and trained personnel to use them? Imagine that the government buys 100 ambulances, but there is no ambulance driver. Would that make any kind of sense? Similarly, we have so many things available today with which to diagnose and manage diabetes. But are they of any use if we cannot use them properly? Therefore, we need to discuss management of diabetes. And if not now, then when? So therefore, let's do it now. The second thing is that when we are exposed to discussion on diabetes, especially on the e-media, on e-platforms, there is a lot of noise which sometimes overshadows the information. We also need to figure out how to filter this noise from actual music. Many times a guideline or a guidance that is written for maybe a practitioner in a Western country may not be actually appropriate for our country. Many times there may be an overlap as well. But then again, we need to figure out how to navigate all this confusion. That is what we'll try to do today. So today I'll be speaking about clinical guidelines for the management of type 2 diabetes in India. We will take expert advice and support from the RSSDI, Endocrine Society of India guidelines, which were published last year. So these guidelines are the result of a Herculean effort, a collaboration between the Endocrine Society of India and the RSSDI. If you need to manage diabetes, first of all, you have to identify it. Isn't that right? And if you have to identify it, you have to test for it. So can we test every Indian for diabetes? There is an expert paper released recently which says that every adult Indian aged 25 and above must be screened for type 2 diabetes and must be screened every year. Theoretically, this is possible, but practically it is difficult. If we were to identify the high-risk individuals, people who are at higher risk of developing diabetes, and we were to screen them, then maybe our yield would go up, our cost effectiveness would go up. So therefore, the people whom we would want to screen preferentially for 2 diabetes would be those with a relatively greater age, maybe 30 and above or 35 and above, though the RSSDI ESI guidelines say 40 to 45. Those with high blood pressure. So A for age, B for blood pressure, C for circumference or waist circumference or abdominal obesity, D for diabetes, and E, just to reinforce, E for excess weight. So we must screen preferentially those who have a greater age, roughly 30, 35 and above, blood pressure, circumference of the waist, diabetes family history, and E for excess weight. Note our emphasis on obesity. It has come twice. Not only are we looking at the body mass index as an indicator of obesity, we are also looking at waist circumference as an index of abdominal obesity or central adiposity. Now, how do we screen patients for type 2 diabetes? Ideally, screening should be done without blood tests because the main aim of screening is to reduce the number of people needing a lab test. We do have Indian risk scores. They can be used, but actually across India, the cost of glucose screening is not all that much. So you might wish to screen everybody with a fasting glucose or with a GTT or sometimes with an HbA1c. What we use most often in our country are a fasting glucose. We'll remember the numbers for this later on, and also a GTT, an oral glucose tolerance test. An oral glucose tolerance test is done using 75 grams of anhydrous glucose. And this very pertinent question from the audience which has come.
How can we prepare a 75-gram glucose solution at home?
So the answer is, you can take any commercial preparation of glucose. It has to be glucose, not sucrose, not table sugar, not fructose. 75 gram of anhydrous glucose is equal to 82.5 gram of hydrous glucose or monohydrate glucose. So if you're buying a packet of, let's say, Glucon-D, you will have to measure 82.5 grams on a weighing scale. Mix that with water, maybe 100 to 150 ml of water. Drink it over a few minutes. And the glucose values that will be tested will be before drinking this and 2 hours after taking it. If you're doing a GTT in a planned way, it would be a good idea to follow a normal regular diet for the previous 3 days and to do the test when the patient is fasting for 8 to 14 hours. HbA1c is used in some settings to screen for diabetes, but it is relatively more expensive, and I would not recommend its routine use in India. So many of our patients have anemia. Some might have a hemoglobinopathy. Some might have renal impairment, other issues. And HbA1c would not be a very accurate screening tool for most of us in most situations. Now, the aim of screening for type 2 diabetes is actually to pick up people in the pre-diabetes phase. If I can pick up a person with pre-diabetes, then I may be able to prevent type 2 diabetes. Also, if I can pick up a person in the early phase of diabetes, I might be able to achieve remission of diabetes. So that is why we want to screen early, because we want to prevent diabetes and we want to aim for remission of diabetes. How is this done? This is usually done with lifestyle modification. If you can achieve a 5 to 7% weight reduction, if you can increase physical activity, just simple things, you can actually prevent type 2 diabetes. It may not be enough just to give this advice. It would help a lot if you have a trained educator or a coach, if you have a structured prevention program. If you're not able to do this in your clinic, then we have good digital therapeutics companies now, which will help your patient from afar. They provide a structured prevention program, which actually helps the patient go into remission or prevent type 2 diabetes. In some situations, we may wish to use medication. The RSSDI ESI guidelines mention metformin and acarbose, but other drugs are being used as well now. Let me speak a little bit about these, because these are also questions coming in from the audience.
In which scenarios do you consider treating a person with oral anti-diabetic agents in spite of being in the pre-diabetic blood sugar range group?
A, if the person fails to achieve desired goals with lifestyle modification. B, if the person is at very high risk of cardiovascular disease. Patient is obese. Patient has high blood pressure. A strong family history of cardiovascular disease. Family history of diabetes. A history of gestational diabetes or polycystic ovary syndrome in the past. Patient is a heavy smoker. In all such patients, we may wish to begin metformin and acarbose. Newer drugs which are available now, which can be used in pre-diabetes based upon good quality clinical trials, will include GLP-1 receptor agonists like liraglutide and SGLT2 inhibitors like canagliflozin, dapagliflozin, or empagliflozin. When will we preferentially use these modern drugs? GLP-1 receptor agonists will be preferentially used if our main aim is to reduce appetite, reduce weight, reduce atherosclerosis, along with preventing diabetes. So if you want to reduce appetite, reduce weight, and reduce atherosclerosis or ASCVD, then GLP-1RA is a good drug of choice. If our main aim is to reduce the risk of hospitalization for heart failure and cardiovascular disease, then SGLT2 inhibitors will also work. So these are drugs that can be used. From an Indian context, suppose you have a patient who has pre-diabetes and who also has a foot ulcer, or who has pre-diabetes and who has painful neuropathy. The patient is not responding to your ulcer management or to your treatment for painful neuropathy. Then you might want to add a small dose of metformin perhaps, or maybe GLP-1RA or SGLT2 inhibitor to optimize glucose further and to help hasten or make more efficient the management of the ulcer or the painful neuropathy. We just spoke about the various tests, and we said that we have fasting glucose, we have an OGTT, and we have HbA1c. Now, let's look at the numbers. We should be aware of these. For fasting glucose, if the number is more than 126 milligram percent, that is diabetes. It is between 100 and 125, it is pre-diabetes. For a 2-hour post-load, allow me to mention here, the correct term for diagnosis for screening is post-load glucose or post-challenge glucose. If you want to qualify this statement further, you will say 2 hour post-load, 2 hour post-challenge, 2 hour post 75-gram glucose load, 2 hour post 75-gram glucose challenge. The normal value will be less than 140. Above 200 is diabetes. Between 140 and 199 is a gray zone, that is pre-diabetics. Note that for screening and for diagnosis, we are not using the word postprandial. And certainly, we are not using the word sugar. That is a wrong word. It is glucose that is being tested. If you have a patient who is asymptomatic, then 2 abnormal values are required: fasting and PP, fasting and post-load, or 2 fasting values or 2 post-load values, or an HbA1c more than 6.5%. On the other hand, if your patient is symptomatic with symptoms suggestive of hyperglycemia, even a single value, which can be a random glucose or a fasting or a post-load or an HbA1c, will suffice for diagnosis. When we monitor our patients for diabetes care, for adequacy of diabetes care, then we can do postprandial. So this is the difference. But even then, it will be a postprandial glucose. Nowhere will we use the word sugar in our discussion. Sugar is okay if you're speaking in colloquial English, but not if you're speaking science. What is the aim of doing all these glucose testing? Of course, first of all, it was to screen for diabetes, then to diagnose pre-diabetes or diabetes, and to try to get your patient to target. But what is the target? In general, our target is based upon HbA1c, and we want an HbA1c less than 7. If you are able to achieve a lower target without causing weight gain, without causing hypoglycemia, that's welcome. The higher the HbA1c, the worse the outcomes, and usually we would not want an A1c more than 8. We also have to walk a tightrope, and we have to keep our patient in what we call the Goldilocks zone. So Goldilocks was this young girl who went into the forest. She went into a house and she saw that one chair was too big for her, one was too little, but the third one was just right. When we manage diabetes, we have to keep diabetes or glucose in the Goldilocks zone. So we must avoid hyperglycemia, but we should also avoid hypoglycemia. And nowhere should we allow the glucose level to go below 54 milligram percent. Things are becoming easier for us now because we have more and more modern medications. And we are able to bring HbA1c down in a much safer manner. But if you have patients who are complicated, who are aged, who are frail, who have cognitive impairment, chronic kidney disease, autonomic neuropathy, multiple comorbidities, or who have poor psychosocial support, do not try to bring the HbA1c to below normal. You might be able to get along with an A1c of 7.5 to 8. And if you have a complicated patient, there's no harm in referring to a specialist and seeking help from them. Whenever we manage diabetes, we have to monitor. Now, monitoring is essential. Like I said, supposing the government buys 100 ambulances, but there's no driver, those ambulances are of no use. But supposing we have 100 drivers as well, we still need to monitor how much petrol did they spend, how much time did they spend going to different parts of the city or the state. If you can monitor that, you can actually make your ambulance service more efficient. Similarly with diabetes, if we monitor, if we audit ourselves, we can actually make our treatment more efficient. We will be able to prevent hyperglycemia and prevent hypoglycemia. Glucose monitoring is actually called a theranostic tool. Theranostic comes from therapeutic and diagnostic. It helps in diagnosing high and low glucose values, but it is also therapeutic because it's a teaching tool for the patient. The patient understands what he or she is going through. And that is why theranostics and therapeutic patient education are an integral part of diabetes care. Now, what is therapeutic patient education. Patient, we understand, it's the person living with diabetes. Education is something that we share with that particular person living with diabetes. But education itself has a therapeutic value. Adding a diabetes education program to quality care, to standard of care, brings down the HbA1c by half to 1%. So in your setup, do try to have a trained educator or a diabetes nurse, create a program, and continue engaging with your patient. Continue ensuring that your patient is educated with diabetes care, with self-management. The person doesn't have to learn everything on day one. Nobody can do that. But first we teach the patient primary skills. Maybe how to take insulin, how to check glucose, how to manage hypoglycemia. Then we teach secondary skills and then tertiary skills. Even if you do not have a trained diabetes educator, you can always begin training your staff. They should be able to share the appropriate information with the patient, which might be about diet, which might be about exercise, about insulin technique. Do the best possible. Do reach out to your own colleagues, to your staff, to colleagues across the country, and you will find that there are so many opportunities for help. We just have to reach out and use them. But education is something that I would like to reinforce again and again. Information provision is not enough in itself. Apart from giving knowledge, you also need to counsel your patient. Giving knowledge would mean you should not eat sugar. But counseling would mean, why do you not need to eat sugar? You have to explain that. Knowledge, counseling, and support. That is the third pillar. Support means, I'm with you. I understand how difficult it is to stop sugar suddenly, but I'm with you. Let's find a way to do this. And if you're able to do this with your patient, you're able to speak in a way that you would want to be spoken to yourself. You're able to listen to your patient in a way that you would want to be listened to yourself. You can actually drive lifestyle changes. This is honestly the toughest part of diabetes management, motivating your patient to change lifestyle. You have to start treatment also. We'll talk about that later. But lifestyle change is key to managing diabetes. 5 aspects of lifestyle change. S for sensible sustenance or diet. S for structured physical activity. And 3 more S's: stress management, sleep hygiene, and avoiding substance abuse. Let's talk about some of these. First of all, diet. A hypocaloric diet would be a good idea, especially for overweight and obese patients with type 2 diabetes. But if you have a woman with pregnancy, a child, an adolescent, then you shouldn't reduce calories. So number 1, reduce the total amount. Number 2, encourage a 3+3 meal pattern or small frequent meals. So meal quantity, meal pattern. And third, meal composition. In meal composition, increase protein, increase high fiber diet, increase low glycemic index foods. But reduce clarified butter or ghee, butter, and cream. Reduce sugar, sweets, and sweetened beverages. So when you're speaking of diet to a patient, do give positives. Madam, why don't you take more of these? And then you add the negatives. Madam, please stop butter and please stop ghee. It would be good to give alternatives also. So maybe your talk would be, I understand how difficult it is for you to give up the ghee and the butter overnight, but why don't you increase the curd and the buttermilk in your diet? If you are kneading the dough to make chapati, why don't you add 10 or 20% of curd or milk to it? The chapati will become very soft. You will not feel the need to put ghee or butter on top of that. So whenever you are taking something away from your patient's routine diet, just try to add something. If you say stop sugar, stop sweets, you might want to qualify that statement with, but why don't you take fruits in moderation? Stop sweetened beverages, but why don't you take lemonade without sugar? So this is the way to explain to your patient how to take a fulfilling and meaningful diet. Physical activity is important. We should encourage our patients to begin exercise, and a minimum of 150 minutes a week is required, a minimum of 30 minutes a day. If you're overweight, you might need to, do more than that, a more intensive regimen to facilitate weight loss. And like we said, stress management, substance abuse, sleep hygiene, these are also important aspects of diabetes care. Many questions from the audience relate to obesity. So let's speak about this. Obesity and diabetes are interlinked. The word diabesity is used because of that. Obesity and diabetes are also interlinked with hypertension, with dyslipidemia. So that's why we have the concept of metabolic syndrome. If you have an obese person with diabetes, the first line therapy would be nutrition, a hypocaloric diet, ensure the optimal food quantity, meal pattern, and meal composition. But usually these don't work alone. So we might have to add other drugs. The drug that is approved for use now is liraglutide. You can begin with 0.6 milligram once a day, subcutaneous. Give that for a week or so, and then up titrate to 1.2 milligram, if required to 1.8 milligram. And you will find that weight as well as abdominal weight do come down. A couple of months later in our country, we will have semaglutide, which is an oral drug, which is also has been shown to reduce glucose and weight. Another drug that can be used is orlistat, 60 milligram thrice a day before meals, or 120 milligram thrice a day before meals. But this might be associated, especially in high doses, with the flatulence. In case the BMI is high, more than 35 or so, then people can consider bariatric surgery, especially if the metabolic response to regular treatment is poor. But otherwise, let's focus on pharmacologic therapy. Now, these slides come from the RSSDI Endocrine Society of India guidelines. And what the Indian experts say is that metformin is the preferred choice. Begin metformin, use it with meals or after meals, use it once daily or twice daily, and try to optimize glucose. Metformin will be contraindicated in type 1 diabetes. It will be contraindicated in pancreatic diabetes or type 2 diabetes with severe hyperglycemia, with symptoms, with associated sickness, or with special situations like renal impairment or hepatic impairment. Metformin is a calorie restriction mimetic. If your patient has come to you with severe hyperglycemia and is already so cachexic, so marasmic, then there is nothing to be gained by giving a calorie restriction mimetic. Already the calories are restricted, either because of loss of appetite, loss of intake, or because of loss of absorption, limited absorption from the gut. In such situations, insulin would be the better drug to begin with. And once your patient is built up, has become a bit more anabolic, then you can think of adding metformin. This reminds us that when you're treating type 2 diabetes or when you're treating adults with diabetes, not all diabetes is type 2. Your patient may have pancreatic diabetes. So take a history of exocrine pancreatic insufficiency, maybe steatorrhea, pain abdomen, diarrhea. Patient might have LADA, that is autoimmune disease, that is type 1 disease. So look for weight loss, other autoimmune diseases. In North India, patient might have celiac disease. In all such situations, instead of metformin, insulin would be a better drug. But still, talking about the vast majority of type 2 diabetes, it is lifestyle modification and metformin, which is the drug of choice, treatment of choice in the beginning. If metformin doesn't work alone, then we have to add. So if your patient has reasonably okay hyperglycemia, not very severe, then we add oral drugs. If there is severe hyperglycemia, then you have to add insulin. And in the Indian guidelines, it is premixed insulin, which is mentioned as a first-line therapy. In case these drugs don't work, you can always intensify, you can up titrate from once daily, you go to twice daily premixed, or you can go to basal bolus insulin as well. Which oral drugs are used? The oral drugs that can be added to metformin include sulfonylureas, glitazones, and DPP-4 inhibitors. We can also add SGLT2 inhibitors, and we can add a non-insulin injectable like liraglutide. How do we decide which of these to give? So first of all, it depends upon the glucose level. If the glucose level is maybe 1 to 2% higher than target, then you might add metformin plus sulfonylurea. Use a modern sulfonylurea, which is safe to use. The two choices are glimepiride and glyclazide MR. We can also use a DPP-4 inhibitor like vildagliptin, saxagliptin, sitagliptin, or linagliptin. And we can use SGLT2 inhibitor like EMPA, CANA, or dapagliflozin. How do we choose these? If you want economy, if you want fast control of glucose, then glimepiride or glyclazide MR. If you want a drug which doesn't cause hypoglycemia at all, and you don't have to test too much, then linagliptin or vildagliptin. And if you want a drug which reduces weight, which also reduces cardiovascular risk of chronic kidney disease, risk of hospitalization for heart failure, then SGLT2 inhibitors. If you want to reduce weight and reduce CV risk, then injectable liraglutide is also an option. And like I said, in a couple of months, we will have oral semaglutide as well. At times, all these drugs may not work, or the patient may come to you with decompensation, metabolic decompensation, with symptoms and signs of severe hyperglycemia. Or there may be a special situation. So remember the S's. S for severe hyperglycemia, S for symptomatic patient, S for sick condition, whether acute or chronic, S for special situations like hepatic or renal impairment or heart failure, and S for surgery. Patient wants surgery urgently. In such situations, insulin is a good drug of choice. Insulin might be temporary. So when we read the Western guidelines, you would assume that once you start insulin, you just have to continue forever and ever. And you have to keep on up titrating, intensifying. But in India, it doesn't happen like that. Many times our patients come to us in an acute stage with decompensation. They come in with florid diabetes. You manage them aggressively with insulin. And a few weeks later, you see that whatever biomedical or whatever psychosocial issue they had, which had caused the hyperglycemia, that gets resolved. And then you can down titrate the insulin, and you can also take the patients off insulin, shift them back to oral drugs. So this is what you must convey to your patient. If you take treatment early, you might be able to get rid of insulin. With experience, you will realize which are the patients who are chronic, the ones who will need insulin for a long period of time, which are the ones who might need insulin for a short period of time. If there is a potentially reversible cause of insulin resistance, which can be any medical, obstetric, or surgical disease, which can be any psychological or social stress, then usually, because these are potentially reversible, usually the insulin will also be reversible. But when we start insulin, we should accompany insulin with education. The patient should learn how to monitor glucose, how to manage hypoglycemia, and how to titrate insulin. We've already discussed how to decide which add-ons to use. Modern sulfonylurea, DPP-4 or SGLT2 inhibitors are used usually. Alpha glucose inhibitors can be used if postprandial hyperglycemia is there. The drugs of choice are voglibose and acarbose. And GLP-1 receptor agonists can be used if weight loss is a priority, if we want to reduce appetite, and if we want to reduce the risk of ASCVD. We are all aware of these drugs, but let me take a few questions from the audience. And most of the questions pertain to the modern glucose-lowering drugs. So one question is,
Sir, can we go ahead with the initiation of SGLT2 drugs or GLP-1 receptor agonist in a patient who is recently diagnosed to have diabetes mellitus, which is which has just crossed the borderline. That is a HbA1c of around 6.6% with fasting blood sugar of 130 and the post prandial blood sugar of around 180. So are the SGLT2s and the GLP-1 receptor agonists the better agent of choice in this group of people?
We have diagnosed diabetes because two numbers are abnormal. The A1C is 6.6, the fasting is 130. First line therapy would be lifestyle modification. But here the question is, my patient is obese. So yes, if your patient has multiple risk factors for ASCVD, including obesity, we can initiate either SGLT2 inhibitor or GLP-1RA. Which of these will we initiate? It's up to you and to your patient. Discuss with your patient. Does the patient want more of weight loss? Then GLP-1RA. Does the patient want suppression of appetite? Then GLP-1RA. Is the patient already at risk of GI side effects, already complains of gastritis, diarrhea, constipation? Then maybe SGLT2 inhibitors will be safer. Does the patient have a history of frequent genital tract infections, a history of frequent UTI, a history of even a single episode of upper tract UTI, that is pyelonephritis? In all these, SGLT2 inhibitors will be contraindicated. GLP-1RA will be safer. When do we treat pre-diabetes with oral antidiabetics? So I guess we answered that. If the patient has severe pre-diabetes, that means the glucose levels are closer to the diabetes range. Patient is symptomatic with maybe something like an infection or a painful neuropathy. Patient has multiple risk factors, and we did those. The family history of diabetes, obesity, smoking, hypertension, dyslipidemia, past history of GDM, past history of PCOS. In such cases, we would tend more towards pharmacological therapy. And if our main aim is weight loss and ASCVD reduction, then SGLT2 inhibitors and GLP-1RAs are good drugs of choice. Many times in India, we are not able to manage with two drugs, so we have to add a third one. This is called TOT, triple oral therapy. And we use this quite frequently. Now, how do we decide a triple oral therapy? Let us classify all drugs into three. Let me take the analogy of a fluctuant abscess. Now, if you have a patient with an abscess, how can you treat? We might want to use a bacteriostatic antibiotic, maybe a bactericidal one, or we might decide that we want to do an incision and drainage. All three have their own role. Similarly, in diabetes, our equivalent of a bacteriostatic antibiotic is our glucostatic insulin sensitizer, metformin and pioglitazone. Our equivalent of a glucosidal drug would be modern sulfonylurea or incretin-based therapy, DPP-4 inhibitors. And the equivalent of an incision and drainage is either acarbose or voglibose, which prevents absorption from the gut, or SGLT2 inhibitor, which promotes excretion from the kidney, or GLP-1RA, which reduces appetite. Armed with this, now we can make a combination depending upon what our patient needs. Metformin will usually be there in all these combinations. You might wish to add one secretagogue like sulfonylurea, maybe another secretagogue like DPP-4 inhibitor, plus a sensitizer like pioglitazone, or a calorie restriction mimetic, or that equivalent of an incision and drainage like SGLT2 inhibitor. If the patient has obesity and weight loss is a major issue, then we will think of adding SGLT2 inhibitor or GLP-1RA. If weight is not a major issue, then we might wish to add sulfonylurea and pioglitazone to metformin. If it is postprandial hyperglycemia, which is the main culprit, then acarbose or voglibose would be a good addition to sulfonylurea and metformin. If we want short-acting secretagogue, so that there is no risk of hypoglycemia, and patient has erratic meal pattern, then another secretagogue that can be used is repaglinide. You can give a combination of metformin and repaglinide. If PP glucose still doesn't fall, you can also give a combination of voglibose and repaglinide. So all these drugs can be used. All these drug combinations can be used. And all these combinations actually help us reduce complications. While we manage diabetes, remember that we have to screen for non-glycemic complications as well. These are the chronic complications. We classify them as macro and microvascular. And remember to screen your patient for retinopathy every 1 to 2 years. For nephropathy every year, do a microalbumin check. For peripheral neuropathy, do remember to see and touch your patient's feet at every visit. And also for macrovascular disease, when the patient has typical or atypical symptoms. The least that can be done is to palpate the foot pulses. And also, we can check the ankle brachial index. Many patients may have atypical angina or anginal equivalents. 2 ABCDE mnemonics which help me remember in which patients to check for CAD, for coronary artery disease. So ABCDE is A for atypical pain occurring anywhere from the angle of the jaw, angle of the mandible up till the umbilicus. B is for breathlessness. C is for claudication pain or clamminess of the skin. D is for dizziness. That means patient might have postural hypotension. Or D is for dry mouth. Dry mouth is also an anginal equivalent. And all these occurring at E for exertion or E for exercise. So if any of these ABCD occur, do think of coronary artery disease and screen your patient carefully. There was another question from the audience, and let me take the opportunity to address that. That question was on hypertension.
What is your drug of choice for your diabetic patients who are diagnosed to have hypertension? Is it ARB or AC inhibitor? And also, sir, do you prefer any specific drug, for example, either telmisartan or olmesartan in the same ARB group, or any agent of choice is fine?
There are different classes of drugs. In a non-diabetic person, when you want to treat hypertension, in most people, in around 70% of people, you will be able to treat with monotherapy. But in diabetes, in 2/3 of patients, you will often require combination therapy. So you have to begin treating aggressively. Remember to focus on lifestyle, reduce salt. From an Indian perspective, what we tell our patients is, why don't you try to reduce salt, reduce table salt, avoid the dangerous peas, papad, pakoda, and pickle. Avoid tomato ketchup. Avoid oregano seasoning. You can take oregano, but if you look at the insert for oregano seasoning, that also contains salt. If I've asked my patient to avoid salt, I have to give an option, I have to give an alternative. So taking rock salt, that is also not very good because that contains sodium as well. So we say, why don't you try all the Indian spices? God has been so good to us. Take more of hing. The English is asafoetida. Why don't you sprinkle oregano over your food? Or maybe add ginger or garlic to your food. Take red pepper, green pepper, black pepper, whatever suits you, and use all the other spices that you have. Fenugreek. Use all these spices to add spice to your food, but avoid salt. The question was, do I prefer an ARB or an ACE inhibitor? So actually, I do prefer ACE inhibitors. ACE inhibitors are not very potent antihypertensives. Calcium channel blockers are more potent. But ACE inhibitors demonstrate what is called a vascular legacy, especially with perindopril. If you prescribe an ACE inhibitor like perindopril, you will be able to improve blood pressure now, and you will be able to reduce long-term complications later on. So just like we have the concept of glycemic memory, metabolic memory, there is a concept of vascular memory or vascular legacy as well. If ACE inhibitor doesn't work or is not tolerated because of cough, then we can also always give an ARB, angiotensin receptor blocker. Most commonly used is telmisartan, but if you have somebody with high uric acid, then losartan would be a better drug. If targets are not achieved with monotherapy, do add either a diuretic, a thiazide diuretic, or a thiazide-like diuretic like indapamide, and or a calcium channel blocker like amlodipine or cilnidipine. Microalbuminuria is an indication for starting an ACE inhibitor or ARB, even if blood pressure is normal. So again, a low dose of ramipril or perindopril would be the best choice. There was another question regarding statins, and this is something that we would like to focus on. Earlier, statins and aspirin were under a cloud, but now we have a lot of data which tells us when we can use aspirin, when we can use moderate and high intensity statins. So the question is moderate and high intensity statin therapy.
Thanks for the answer, sir. One more question. How will you choose between moderate and high intensity statin therapy for all your type 2 diabetes mellitus patients?
Can be used for primary prevention. So that means that anybody who does not have established CVD, but who has diabetes, who has a slightly high LDL, can take a statin. This is primary prevention. The patient does not have established CVD. In whom will we advise primary statin therapy? And this will be a low or moderate dose. These will be people with diabetes aged more than 40, people with long-standing diabetes, those with a family history of CVD, those with a high 10-year risk of CVD. And this can be calculated using validated risk scores. You must have heard the word Framingham risk score. What is most useful for India is Q risk, capital Q, capital R, Q risk 3. This comes from United Kingdom. It is a multi-ethnic patient pool that they have used, and you can easily put in Indian or Bangladeshi or Pakistani. You put in your ethnicity, and you will be able to calculate your CV risk. So this is for primary prevention. Suppose the patient already had ASCVD, then it becomes secondary prevention. Then everybody must be given statin. Then you need to give a moderate or high dose, atorvastatin 40 to 80 milligram, or rosuvastatin 20 to 40 milligram per day. For people without ASCVD, try to reach a target goal of less than 100 for LDL. If established ASCVD is there, then our target goes down to 70 LDL, 70 milligram percent. And if patient is at very, very high risk, extremely high risk, maybe patient has aortic aneurysm and ASCVD, then even an LDL of 55 milligram percent is justified. We do focus on LDL, but we should not forget triglycerides. If triglycerides are high, then the first line of treatment is lifestyle modification and glucose control. Give insulin if needed. Insulin will bring down triglycerides. And if all this doesn't work, after adequate lifestyle optimization, adequate glucose control, still TGs are high, then a fibrate should be added. You can give a statin and fibrate together. The chances of myalgia are more, the chances of myositis are more, so do keep on taking a regular history. If your patient has myalgia, the first line therapy for that would be vitamin D supplementation. We've spoken of statins, and we said that statins can be used for primary as well as secondary prevention. Aspirin was also used like that earlier, but now it is suggested that aspirin should be used only in established ASCVD, only for secondary prevention. If the patient has had a recent MI in the past 12 to 15 months, then a dual antiplatelet therapy is suggested. You can use aspirin plus clopidogrel or aspirin plus prasugrel, 10 milligram OD. Prasugrel is more potent, chance of bleeding tendency are more. Or aspirin plus ticagrelol, 90 milligram BD. Here, the chances of bleeding tendency are less. So the cardiologist will decide whether to give aspirin plus clopidogrel prasugrel, or ticagrelol, but it will be a dual platelet, antiplatelet. If the patient has had an atrial fibrillation after an MI or during an MI, or is at risk of atrial fibrillation, maybe because of valvular heart disease, then again, dual therapy is required. Dual, it is not triple anymore. And the dual will be aspirin plus a NOAC, a novel anticoagulant drug. An example would be dabigatran. We've spoken of so many aspects of diabetes now, but let us remember our elderly population. And while our targets should be similar for the elderly, we should go a bit slow. Avoid hypoglycemia, do a proper geriatric assessment, screen them for frailty, and don't be too aggressive in chasing glucose levels. Because if you cause hypoglycemia, you actually might end up increasing the risk of fall and increasing the risk of fracture. When we are managing the elderly, we should also be aware of sarcopenia, which means any of the following, any two of the following three: loss of muscle strength, loss of muscle function, loss of muscle mass. If this is there, then you manage sarcopenia with lifestyle modification, with resistance exercise, optimized protein, calcium, and vitamin D intake, and if required, hormone therapy, testosterone or estrogen. Like I said, we've discussed so many aspects of diabetes, but do not hesitate to refer to a specialist. If you have any atypical presentation, you feel that things are not right. I am treating an adult, but perhaps he has a different type of diabetes. It may not necessarily be type 2 diabetes. Then do refer to an endocrinologist. If you have somebody with type 2 diabetes, but there are multiple complications, then also no harm in referring. And if there is any acute, life-threatening, limb-threatening, or organ-threatening complication that you feel your setup is not equipped to handle, then again, it would be a good idea to refer.
How will you follow up the patients with pre-diabetes? How frequently do you follow up? And with which test do you follow up these patients? Is it OGTT at each time of follow-up, or is it only a fasting blood sugar with an associated HbA1c?
So I will follow them up regularly. If they are being treated only with lifestyle modification, then maybe a fasting and a postprandial once a month will suffice in my setup, and an HbA1c after 3 to 4 months. I will tell my patient if that there is sudden change in weight or there is any unexpected symptom, then they should come back earlier. The sudden change in weight may be good. It is possible that it is because of successful lifestyle modification, but it also might be because of inadequate glucose control. How will I follow up? Like I said, a fasting and a postprandial, not a GTT. I will not do a GTT for follow-up. A fasting and a postprandial every month, and an HbA1c every 3 to 4 months. The toughest question I kept for the last, and that was, how will I counsel my obese patient who is finding it difficult to reduce weight? So I myself live with obesity. It is quite challenging, actually. So we will counsel our patient that even if you try to lose weight, even if you follow a healthy lifestyle, there is evidence to show from the look ahead study that this will reduce the risk of CV complications. So the very fact that you are following a healthy lifestyle is keeping you healthy. Second is, if lifestyle and exercise alone do not help, maybe we can optimize that. Just look for issues which might be occurring. Maybe you're doing only resistance training. So why don't you add a little bit of aerobics? Maybe you're doing aerobics which are limited just to the lower limbs, to the proximal muscles. Why don't we begin exercising your distal muscles as well, or your upper limbs? And this reminds me that we've already spent nearly an hour, and there is research to show that if you sit in one place for more than 30 minutes, you have a CV risk equivalent to that of smoking a cigarette. So why don't we all stand up, march on the spot, and why don't you all stretch for the sky? It's a good idea to remain physically active, whether you are delivering a talk or whether you are listening to one. So do keep all your limbs moving. This is called NEAT, non-exercise thermogenesis. So try to keep on exercising your various muscle groups, and this will help you reduce weight. Secondly, for diet, there is something that we call the 80-20 rule. This is known as Pareto's law. Now, Pareto was an economist who said that 80% of all the wealth of a country is concentrated in the hands of 20% of people. That is true. From a diet point of view, mostly people do try to follow their doctor's advice, but 80% of the time, it is only 20% of their food intake which is the culprit. So we'll say, why don't you go back to your kitchen or to your dining table and see what's happening and see where those hidden calories are coming from. They will be hidden. So a common situation will be, yeah, everything else is fine, but yes, I was adding a dollop of butter to my prantha every day. The rest of the day I'm fine. Or I did take a little bit of Haldiram fried namkeen, and that is very tasty because it has a lot of oil. Or maybe I do not take any sweets, but I do take namkeen mathi, which is again fried and which has a lot of salt. So try to explore within the kitchen, within the dining table, what issues you're facing with lifestyle. If you've modified all these, so number one was reassurance. Reassure your patient that you are on the right track. Number two, have a relook at meal patterns, at exercise, and see if you can find scope for improvement there. Number three is relate to your patient. Talk about stress levels, talk about sleep hygiene. Now, if you sleep late, the cortisol, the counter-regulatory hormones go up. If you're under stress, cortisol, dopamine, these counter-regulatory hormones go up. Dopamine goes down actually. And these also contribute to insulin resistance. So find other reasons for insulin resistance. If all this doesn't work, then you discuss medication. So we can add an SGLT2 inhibitor. We can add a GLP-1R. Also see if the patient is receiving insulin or receiving medication which is causing the weight gain. There might be high doses of insulin being used, especially regular insulin, and pioglitazone might be on the prescription list. So these can be reduced or stopped if possible. Dead weight is another issue. Patient may say that I am not losing weight, but when you examine the patient has edema, and there might be 5 or 6 kg of water in that patient's body. So you fix up the edema, you give the appropriate treatment, you stop offending treatment. So these are the ways in which we handle a person with resistant obesity. I hope I have answered all the questions that we have received from the audience. But if there is anything else that you would like to know, please do not hesitate to reach out to us. We are always available through the DocPlexus platform to continue this discussion about diabetes control. I'm confident that if we work together as a team, we will be able to make India the diabetes care capital of the world. And we will be able to make our country free from diabetes complications. Thank you, and wishing you all the best for your career in diabetology. But all this discussion will be of no value if we do not put it into practice. So let's begin practicing good diabetology, good diabetes care. Let's begin practicing good clinical sense, reinforced by the guidelines that we have just discussed. If we can convert this theory into practice, we will be able to improve the outcomes of our country. I wish you the best ahead.
Dr. Joel is a consultant physician in the Department of Endocrinology and Diabetes at Central Specialist Medical Center in Trinidad and Tobago. Dr. Joel pursued his degree of MSc in Endocrinology and Diabetes from Queen Mary University of London, and he also holds the degree in MRCP as well as FRCP. Dr. Joel, kindly go ahead with the presentation.
Thank you very much for your warm welcome. So it is a pleasure and a privilege to be a part of this summit, so organized as part of the celebration, if you wish, for World Diabetes Day on the 14th of November. And a special hello to my friends around the world as we discuss about one of the most frightening scourges of diabetes. It has been estimated that there are 463 million people living in the world. Can you imagine? 463 million people living worldwide with diabetes. And the scary thing is, 1 in 2 wouldn't even be aware that they have this problem. I wanted to share my presentation about the diabetes deluge. We've been talking about the global epidemic of COVID-19 since 2020, and we have had a creeping separate epidemic, and we know that this has been a very powerful risk factor for death, ventilation, and hospitalization in persons infected with COVID-19 as a result of reduced immunity and other factors. However, this has been a burgeoning problem globally, driven by the separate epidemic of obesity. It's almost like thinking about obesity as the driver. And when you look into the rearview mirror, you see diabetes, high blood pressure, high cholesterol, and all of the attendant risk factors for heart attacks and strokes. And I just thought that a nice way of starting this lecture about a chronic illness like diabetes would be with a quote from Buddha. Without health, life is not life. It's only a state of languor, suffering, an image of death. And perhaps when we think about a chronic illness and we think about the micro and macrovascular complications of diabetes, one suffers before death. It is a leading cause of blindness among working aged persons, a leading cause of end-stage kidney failure, the number one reason for non-traumatic loss of limbs. At my hospital in South Trinidad in the West Indies, we have a separate ward for persons with diabetes, foot infections, ulcerations, and amputations. And you're 2 to 3 times more likely to have a heart attack and stroke if you're a person with diabetes. So we've been talking about the threat, about bird flu in the past, COVID-19 since the start of 2020. Our leaders recently attended a COP26 climate change conference in Glasgow, Scotland, but obesity has remained the biggest global threat and perhaps continues to be under-recognized by world leaders and healthcare administrators. More than a decade ago, there was a meeting held by the West Indian leaders in Port of Spain, Trinidad. Fans of cricket would know that that's also the site of the picturesque Queen's Park Oval. However, at Port of Spain, the goal was to tackle the burgeoning rise of chronic NCDs, diabetes, hypertension, heart disease, strokes, respiratory problems. And after a decade, we are still grappling with this. It was just merely a talk shop, similar probably to that climate change conference, and we're still struggling with problems starting at primary schools, starting in childhood, and escalating into younger adults. So it has been likened by some of the doctors in America as almost being a car crash in slow motion, that you are seeing the problems beginning at a younger age and then leading to untold socioeconomic, psychological, and physical suffering. And speaking of cricket, so our viewers would remember that fearsome foursome, that pace quartet that the West Indies team had in the early 1980s and dominated the cricket scene. You know, there was Andy Roberts, Michael Holding, a whispering death, toured India so many times, and now still tours as part of the commentary teams. There was Croft in the back, but my favorite was Joel Garner, because he shared my first name. So when we grew up, you know, everyone would be so excited saying Joel was there, Joel Garner. And that fearsome quartet led and decimated. They were physically fit. You couldn't see an inch of fat on them, in stark contrast to so many of our players now, in which you can see that midriff, that paunch in the middle, and that abdominal obesity driving up that risk for type 2 diabetes and the attendant features of the metabolic syndrome. And in fact, our first gold medal winner, Paisley Crawford, in 1976, he blazed to gold in the 100 meters at the Olympic Games in Montreal. He has become a spokesman because for type 2 diabetes and hypertension, because following his retirement from athletics, from track and field, he developed the metabolic syndrome, and as a result of poorly controlled type 2 diabetes, he had numerous microvascular complications. So he has become a leading spokesman in the West Indies for improved healthcare and indeed healthy lifestyles as we attempt to prevent the metabolic syndrome and its various components. And just recently, we congratulated the Indian javelin thrower who won your first track gold in javelin, Mr. Chopra. And you would be interested to know that we had our second gold medal at the London Olympics in 2012 as our javelin thrower, Keishan Walcott, struck gold. It was the very first time that a non-European had won gold in the javelin. And we know that from these supremely fit athletes, we have moved into increasing obesity. So some of the guidelines in the West Indies for primary care doctors have been published about 2 years ago by a group called CARPHA, and that is the Caribbean Public Health Agency. The acronym is CARPHA, C-A-R-P-H-A, and these guidelines have been published, and I do perhaps for really an update. They were published in mind for doctors at health centers throughout the West Indies. And this association was set up on the behest of the governments around the Caribbean to guide certain public health measures. However, as a result of the COVID-19 pandemic, a lot of the focus and emphasis would have been diverted towards this infectious illness rather than some of the other chronic diseases. And the guidelines that we will be discussing are similar to what would be published from the American Diabetes Association and their counterparts in Europe. And some of the goals when we're talking about a person with diabetes, for blood pressure 130 over 80, and preprandial and postprandial targets there, you can see similar to American Diabetes Association. In the West Indies, most of us would use milligrams per deciliter, and the hemoglobin A1C under 7%. So although that target may be different, as we know that it's part of the art of medicine that you want to individualize or personalize your goals. So someone who's younger with a longer life expectancy, perhaps the HbA1c under 6.5 in order to reduce microvascular complications. And you want to be very tight. That's one of the emphases in these guidelines, is that you want to be tight in terms of your glycemic control very early upon the diagnosis of diabetes, and especially since there is a legacy effect. We know that the body has a metabolic memory, so that persons may find that in the long term there is a reduction in cardiovascular risk if you have very good glycemic control. And the focus too is universal, that you don't want to be glucocentric when you're looking at someone with the metabolic syndrome, that you are addressing also lipid profiles, the total levels under 200, low density, so lipoprotein in most patients will be under 100, and if that individual is high risk, as low as 70. And the high density, so lipoprotein, another aspect of the metabolic syndrome, being more than 40 in men and over 50 in women, and the triglycerides less than 150. So I know that my friend and mentor, Dr. Sanjay Kalra, has focused a lot on a term coined called glucochronology, in which he looks at the link between glucose levels and the various aspects of endocrinology. And it's a beautiful word because it looks at so many pathophysiological aspects that may increase someone's blood sugar. And we know now that it's not just about insulin. Of course, most persons with type 2 diabetes may have obesity that creates a milieu of insulin resistance, and then eventually there would be depletion and perhaps the apoptosis of the beta cell as a result of gluco and lipotoxicity. However, we know now that there is a complex interplay involving hormones at the gastrointestinal tract, the incretins. One of the huge studies recently out called SURPASS is actually looking at a drug that will be acting at both GLP-1 and GIP. So it's a twin cretin effect on that particular drug that is expected to be approved in the latter part of this year. It's also looking at various aspects of the islet cells in the pancreas, reduced glucagon from the alpha cells in many of these agents. You're also looking at increased glucose uptake, reduced glucose uptake at the muscle that may cause a rise in blood sugar. And of course, at the level of the kidney, that host of drugs now, that class of drugs, SGLT2 inhibitors, that is creating so much excitement in the world, not just in the diabetes and endocrine, but also cardiology and nephrology. And we'll talk a little bit more about that in the presentation. So the ominous octet coined by Ralph DeFronzo in the United States, looking at so many pathophysiological changes associated with diabetes and indeed that interplay of glucochronology, that complex interplay where there are so many other factors apart from type 1 and type 2, but other factors that may account for a rise in blood sugar. So back to the West Indian guidelines or the CAFA guidelines from 3 years ago, that when we are looking at the delivery of care to patients with type 2 diabetes, that we are looking at the presenting complaint and always remembering that the patient concerns remain at the center. They remain integral to the center. It's patient-driven recommendations, individualized or personalized medicine. And the past medical history, of course, we're looking at risk factors, smoking and alcohol, and we will also be discussing those, and different exercise patterns. Lifestyle changes remain the cornerstones or pillars in management. The family history, most persons in Trinidad and Tobago would either be of Southeast Asian or of the African ancestry. And as part of the Indians or diaspora, we find that burgeoning metabolic syndrome, that fat around the tummy, is also present, and with an increased risk of type 2 diabetes and vascular disease at an early age. Talking about traditional herbal or over-the-counter remedies, a lot of patients will often find that they have spoken to the pharmacist, they've spoken to a neighbor before actually going to the doctor and using all these remedies like bitter melon, so Karaili. Many of the patients are fans of things like moringa, what we refer to as Saijan here. And before actually seeking medical care. And that time, of course, the sugar has risen above 500 milligrams per deciliter. And we know that as a result of so many ultra-processed foods, there have been studies showing that perhaps 25 to 30% of persons may be at an increased risk of depression. Perhaps it's time that we consider that as part of the metabolic syndrome, and we are not exploring the psychosocial aspects of care, which impacts on not just blood sugar, but also blood pressure and cardiovascular risk. So when we're thinking about a patient-centered approach and we're exploring the fears and concerns that so many of our these persons encounter, It's useful to think about, according to CARFA, in terms of an acronym FIFE. So FIFE, the feelings. How do they feel knowing that they have diabetes? Diabetes distress. Some individuals have hopelessness, helplessness, and worthlessness. They have reduced sleep. They're thinking about the future, and they've read about the complications, the micro and macrovascular implications of diabetes, exploring their feelings, ideas. What do they think about ways to manage their health and obtaining targets that we discussed? Functioning. How does having diabetes affect everyday activities and expectations? What do they hope to achieve from the consultation and health partnership with you? Persons, and we may be surprised, there may be subtle signs and symptoms of high blood sugars, like the tingling, numbness, burning. One of the old terms that we use here, junjuni. So that sensation of pins and needles, and that actually affects sleep, quality of life, and it's underexplored. Blurred vision, it might be relevant, especially as we think about a virtual world wrought upon us since the start of the pandemic. Persons may have sexual dysfunction, underexplored as a result of the stigma so attached to that, and the machismo male is less likely to offer that as being one of his concerns unless the doctor directly explores. Low levels of testosterone, frequently a part of the metabolic syndrome too. And it would be worthwhile for the doctor to look at the feelings, ideas, function, and expectations at most of our encounters. So it's not just a matter of thinking about adherence to medications, and of course the lifestyle and the diet and exercise remain important, and looking at a list of biochemical results. The FIFE, the feelings, ideas, function, and expectations, are structured approaches towards someone who is diagnosed with diabetes. And in terms of the physical examination, these would be well known to our viewers. And the general appearance, we're looking at the body mass index and various facets. If I could remind that the skin, as we know, represents what is happening internally. So the skin and the eyes, the mouth, those are all windows to the soul and underexplored by the clinician if you are like me, and we are uncertain about ourselves in terms of ophthalmology. Patients should be sent for a dilated fundus exam annually, and different parts of the physical examination would remain essential in somebody with diabetes. And of course, we should be discussing about goals. So in the office, and we know about the various blood investigations, similar to so many of the international guidelines, the HbA1c lipid profile, kidney function, and a thyroid function. I find that to be useful, especially in the type 1 diabetic patient annually, and in the type 2 patient, particularly with hyperlipidemia. Persons may want to consider also doing a thyroid function as a routine screen, at least annually. So if I can emphasize at this point, a spot urine protein should be sent off for microalbuminuria. It is a potent cardiovascular risk marker, and apart from being an early sign for kidney damage, and we know that this new class of drugs, the SGLT2 inhibitors, certainly cause a reduction in microalbuminuria, even in persons who are not diabetic. So Jocelyn, who is a well-known specialist in the field of diabetes in the United States, coined a beautiful phrase that I wanted to share, that we could talk about genes from our Southeast Asian ancestry, or the African ancestry in the West Indies, and indeed around the world for many of our doctors at this diabetes summit, including the Latin Americans. But since you cannot pick your parents or grandparents and avoid diabetes, do the next best thing and not get fat. To inherit diabetes is blameless, but to acquire it through obesity when you have a hereditary tendency to it may be blamable. So it's analogous to thinking about genetics as a loaded gun. and lifestyle pulls the trigger. And we know we've been talking about so many of the complications, and these are just some of the images globally of patients with diabetes, foot ulcers, infections, and indeed a dreaded Charcot foot, including some individuals who've had amputations, and along with retinopathy. So my wife is an ophthalmologist, Neela, and she was instrumental in a study done locally in which we looked at persons with a sign called the slipping slipper sign. So it was a local marker that was found that persons who complained of having slippers that slipped off and they were unaware. They were unaware that they had lost their slipper. So they were walking, their slipper was left behind. Persons who had that slipping slipper sign were more likely to have peripheral neuropathy. So that was the first finding. And then when she looked at persons who had that sign, the slipping slipper sign, every single individual had features of diabetic retinopathy. So that perhaps could be one of our questions that we asked at the bedside. Have you ever noticed that your slippers have slipped off and you are unaware of it? The slipping slipper sign, and that has been validated by different doctors throughout the West Indies as being a marker for peripheral neuropathy, and also, so in our study at San Fernando Hospital in South Trinidad, to be strongly correlated with diabetic retinopathy. So back to the CARFA guidelines as we think about a multidisciplinary team. The endocrinologist, along with the primary care doctor, is often involved. As we know, with such a multidisciplinary approach, the vascular surgeon, ophthalmologist, the cardiologist and nephrologist now believe that they could manage the diabetes since the advent of SGLT2 inhibitors. It's always a cause for concern. The neurologist and obstetrician, but the patient remains central to that. And of course, all of the auxiliary healthcare workers that do such wonderful jobs in the management of the diabetic patient, including the dietitian, the physical coach, the certified diabetes educator that perhaps would be interacting so much more with the patient than many of the clinicians, the pharmacist, mental health care worker, and podiatrist. However, many of these patients are underserved in places like the West Indies because we do not have the sort of multidisciplinary approach readily available to them. So frequently, if you're seen in one of the primary care centers around the countries, around these parts of the world, you are not going to be seeing a podiatrist. Many persons, especially in a busy clinic, are not being screened for mental health issues. Perhaps they are not seeing a vascular surgeon in a timely manner, or the ophthalmologist. Unfortunately, as we see so many great screening programs like the Paula Carr retinal screening in the UK has been found to improve outcomes in terms of diabetes eye care, and we don't have that available readily in parts of the Caribbean. So these recommendations, when we're talking about the diagnosis of diabetes, is very much in keeping with the rest of the world. And there are different ways. The fasting blood sugar level less than 100 would be viewed as normal, and impaired glucose would be rising at 100 to 125, or pre-diabetes would be the term there, impaired fasting glucose, and you would be a diabetic if your fasting level exceeds 126. The HbA1c, we have issues with standardizing in terms of the diagnosis of diabetes, but levels exceeding 6.5%. The glucose challenge, it remains an older way to diagnose the diabetes. Luckily, we don't have to look at the urine on the grass and see if ants are attracted to it anymore. Neither do we need to add Benedict's solution to look for brick red appearance. So as we now have these proper blood investigations, so the urine tests have been antiquated now. They are now antiquated, and the glucose tolerance test. So following a 75-gram glucose drink, the level exceeding 200 would also be one of the ways to diagnose someone with diabetes. And of course, those individuals with classic osmotic symptoms of hyperglycemia and a random blood sugar level more than 200. So there are two different ways, and as part of the CARFOS guidelines, very much in keeping with the rest of the world. And in terms of drug use, what would be best for somebody who is newly diagnosed with type 2 diabetes as part of this initial encounter? Intensive lifestyle interventions will remain, as we said, the pillars. And then metformin, it's an old drug after more than 50 years, but boy, is it a good one. It has been found to be useful in terms of long-term cardiovascular benefits. According to the classic UK PDS, it may even help with weight. And we know that it's an insulin sensitizer. It's cheap, readily available, and once patients are not having the initial GI side effects, very well tolerated and a useful tool in the therapeutic armamentarium for type 2 diabetes, particularly in the Caribbean. However, we know now that American Diabetes Association recommendations have said that persons with cardiovascular issues, you'd want to consider perhaps a GLP-1 receptor agonist. So as I mentioned, watch this space that there will be a twin creatine drug that will soon be approved that will be an agonist for both GLP-1 and GIP, or an SGLT2 congestive heart failure, or in patients with CKD, you would want to consider the SGLT2 inhibitors. Definitely, there would be a reduction in heart failure risk and mortality in those individuals. So those SGLT2 inhibitors have created a huge furor and excitement in the world of cardiology, nephrology, and endocrinology. However, back into the Caribbean, and indeed in many of the resort sport settings, our next step is obtaining a sulfonylurea, and there has been a wealth of research about some of these so-called newer generation sulfonylureas as being weight neutral and very safe as one of the first-line drugs, especially in persons who may be intolerant of metformin or as an add-on drug to metformin, and that is freely available in the public sector throughout the Caribbean. Drugs like glycoside, modified release, or glimepiride. So, and the glitazones were moved away from that. It's no longer readily available here. Unfortunately, pioglitazone remains, of course, an excellent drug, but there were some dark clouds swirling about bladder cancer risk. And we know the story with rosiglitazone, unfortunately, in terms of the CVD issues. The DPP-4 inhibitors, also useful tools in the armamentarium. So these recommendations, I just want to emphasize, were pre-COVID, and perhaps there will be changes in those parts of the Caribbean that would be available, that would be able to afford drugs like the GLP-1, so receptor agonists. Some of them are available here now, like liraglutide, the SGLT2 inhibitors, all of those commonly used in parts of the US now are available within the private sector at a bit of an exorbitant cost. However, the benefits certainly outweigh risks when we think about its use in patients with congestive heart failure and CKD, even in those, as we said, who are not diabetic. So dapagliflozin, empagliflozin remaining, and canagliflozin readily available in the West Indies, and remaining first-line drugs in patients who have congestive heart failure and kidney disease. Some other GFR, perhaps 25 minutes for that. So in terms of the guidelines in the Caribbean, in the West Indies, there is no hard and fast rule as to where to go after metformin, and the American Diabetes Association now would have separated this. So I know in different parts of the world will be leaning towards those persons with high risk factors or different medical illnesses, as certain drugs will be more readily available. As I think that the SGLT2 inhibitors, perhaps when they become generic, and I know that India will be leading that charge, when the SGLT2 inhibitors become more readily available in terms of cost, those might actually be first-line drugs in the management of type 2 diabetes. I think that will be one of the paradigm shifts in global diabetes guidelines. So insulin, as we celebrate 100 years since Frederick Banting and Charles Best's Nobel Prize-winning discovery and a life-saving drug for patients with diabetes, we wish to say that it remains still an expensive drug for persons, many of these insulin analogs for persons seeking pens or even insulin pumps. And one of the themes for World Diabetes Day on the 14th of November is actually improving access to patients in diabetes care. And we still find that many of these novel technologies, after 100 years, they are still extremely expensive. And when we're weighing pros and cons for drugs, of course, we're exploring safety, tolerability, efficacy, and price. So this life-saving treatment still remains inaccessible to many of our patients. This year was a reminder that by the time patients would be diagnosed with diabetes, they have already lost up to 50% of pancreatic function. So metformin, sulfonylurea, unfortunately for many persons in a resource-poor setting, the next step is insulin rather than the DPP-4 inhibitor and SGLT2 inhibitor, or even some of the other drugs available according to international guidelines. So it's important for us to emphasize to our patients that we're going to have to intensify treatment very often, because part of the clinical inertia that we often encounter as doctors is that patients are afraid. Patients are often afraid of insulin for different reasons. They're afraid of needles, and that's why a lot of our persons are actually hesitant to even go for the vaccines. So in the Caribbean, the COVID-19 jabs. And we have to actually say that, and perhaps with a loved one as part of the clinical encounter, that having insulin may just be another step in treatment. And it's not the end of the road. It doesn't mean that you've reached a bad type of diabetes. It doesn't necessarily mean, as part of the misconceptions, that you're going to soon die. Perhaps persons may have had a neighbor who started insulin and then died soon afterwards. And the perception is that the insulin was responsible for the mortality, rather than the fact that it may have been started too late, and that individual may have had incipient micro and macrovascular complications prior to the commencement of insulin. So education remains paramount. A reasonable goal, as we said, according to CARFA guidelines, remains at 7%, but we want to individualize that. And there are patient-related fares as part of the clinical inertia. And this is a slide from diabetes care, that there is so much fear still around, not just needles and the whole idea of injections, but also hypoglycemia, the fear of weight gain, the stigma of having to inject, especially as now we have the vials and syringes instead of the insulin pens, so in the public sector. And there is a perception too that there is personal failure, and this would be contributing to diabetes distress. We spoke about that we're not going to be using insulin as a threat or as a drug of last resort, but indeed something that is just a step up, just another tool as part of our guidelines in achieving goals towards a hemoglobin A1C of under 7. So it remains, trust remains important, not just into diabetes, but all chronic diseases. And indeed, trust has been lacking in the COVID-19 response by so many of the governments. And perhaps that is one of the reasons why we're seeing so much vaccine hesitancy in places like the Caribbean. Back to CARPA guidelines once more, there are just some recommendations of how insulin should be adjusted and the different types of insulin available. Many of these are found in the private sector, but in the public settings, we have mixed insulin, the 70 and 30%. There is insulin R and N free available with a violent syringe. Unfortunately, we continue to have issues to access pumps for our patients. Continuous glucose monitoring is not yet available in many of the diabetes centers throughout the Caribbean. And the use even of pens, insulin pens, is something that remains out of many patients' price ranges. So I just thought I wanted to share some clinical vignettes with our viewers. There was a 23-year-old man that we saw this year with nausea, weakness, and abdominal pain. He was admitted to hospital. He was diagnosed with diabetes 6 months before and started on gliclazide MR by his primary care doctor. He had a body mass index of 19, so he was slender, but he had weight loss. His glucose on admission was 486 milligrams per deciliter. His hemoglobin A1C was 15%. And it's just a reminder to primary care doctors that someone presented nausea, weakness, abdominal pain was found to also be acidotic. He had a classic triad of hyperglycemia, metabolic acidosis, and hyperketonemia. His hemoglobin A1C, of course, was woefully uncontrolled, and someone like him more likely would have been a type 1, so diabetic, and starting off on an oral hypoglycemic agent at that point would have been risky. So unless you're thinking perhaps whether he had some type of MODI, I'm not sure if that was the thinking. So at the time of the diagnosis, and they started a sulfonylurea. But once someone is having weight loss and symptoms and with a hemoglobin A1C of 15%, he of course is screaming for insulin to attain control. Part of the CARPA guidelines, in fact, we'll be saying that those younger patients, newly diagnosed, especially if poorly regulated, you'd want to refer to a hospital setting. The chronic refractory hypoglycemia with metabolic decompensation, recurrent episodes of hypos, uncontrolled gestational diabetes, those with life-threatening complications, including hyperglycemic, hyperosmolar states, or diabetics or ketoacidosis, should be immediately referred to a hospital setting. So another vignette involves a middle-aged man, 55 years old, with hypothyroidism due to Hashimoto's. He's having fatigue and weight loss. He has a body mass index of 22. His thyroid function is normal. So he's having tiredness and weight loss with normal TFTs. His creatinine is normal. His HDL is 60, triglycerides 77, and his glycemic control is poor. He started on metformin, 1 gram twice a day, and gliclazide, 160 milligrams twice daily. So he's been a diabetic for the last year. So someone with him, someone with his medical issues like Hashimoto's, thyroiditis, that immediately, of course, should send red flags that he is someone who could have a host of autoimmune illnesses, as we know that these hunt in packs. So if you see one autoimmune illness, it should prompt you to see to possibly be looking for others. And someone who's having tiredness and weight loss, perhaps you'd want to look for issues with the adrenals. It's not having hypos, so admittedly, but that could still be one of the associated symptoms. He may be malabsorbing. You may want to think about looking at his full blood count. Perhaps the type of diabetes that he has is not type 2. Although he's 55, he has something autoimmune, he's losing weight, his body mass index is slender, 22. And what's interesting is that his HDL is 60, his triglycerides 77, And we know that most patients with type 2 diabetes, as part of the dyslipidemic pattern, they often have a low level of HDL and a high triglycerides. So that represents part of the metabolic syndrome. And it's so often seen in diabetic dyslipidemia and a type 2 diabetic. So persons with type 1 diabetes very often may have a high level of HDL, or the triglyceride level will be lower, especially newly diagnosed type 1. So whether or not you have to consider different facets in this case, you're thinking about the possibility of type 1. You'd want to send someone like him perhaps for a C-peptide, an anti-GAD, or the islet cell antibodies, and of course screen for the possibility of coexistent autoimmune illnesses. And wonder whether it seems that he has already failed maximum therapy in terms of oral hypoglycemic agents. So part of the treatment of those patients who might be obese, who might be overweight, and we're thinking about, of course, metabolic surgery if the body mass index exceeds 35 with chronic illnesses, and certainly over 40. Pharmacotherapy in terms of dealing with this global epidemic of obesity remains underserved in the Caribbean, unfortunately. So in terms of intensive lifestyle intervention, we often have to move, apart from medications to achieve weight loss, we have to move to metabolic surgery. That's our next. There's another vignette I thought would be useful. A 50-year-old woman was admitted with diabetic ketoacidosis a month ago, and she was newly diagnosed at that point. She was started on insulin NNR. The sugars were excellent following discharge, despite decreased doses of insulin on follow-up, and she stopped her medications after 3 months. So she was admitted to hospital with diabetics or ketoacidosis, but following discharge, the sugar levels improved and she stopped it. Her body mass index was 32, and she had evidence of acanthosis nigricans. A C-peptide is normal. So it's important then that we look at patients in a holistic manner, that this individual was admitted with diabetic ketoacidosis. Perhaps the hemoglobin A1C at that point would have been elevated. The C-peptide was normal, and she had acanthosis nigricans, and of course a cutaneous marker for insulin resistance, and there were no microvascular complications on review. After 6 months following a cessation of insulin, the hemoglobin A1C was 5.8%. So this person was found to have, and if I can add in at this point as part of the vignette, her islet cell antibodies and anti-GAD were negative, and was believed to have ketosis-prone diabetes. So as much as we would like them, as we know, patients don't fit into these little holes, and we can say, okay, we're going to pigeonhole you into type 1 or type 2 diabetes, or gestational, or perhaps diabetes due to a secondary cause, MODY or LADA. Patients often do not fit these patterns, and ketosis prone to diabetes involves many individuals, particularly so Caribbean persons in places like the United States. It was referred to as flatbush diabetes, J-type, types 1.5 or type 3 diabetes, but persons with uncontrolled blood sugars admitted with diabetics or ketoacidosis, and then having an apparent resolution of the blood sugar and actually stopping insulin. Their antibodies are negative, C-peptide levels are normal. However, those persons may often be admitted to hospital with ketoacidosis in the future. You'd want to follow them up. Some persons may actually have antibodies, some may not, and there are actually ways to classify individuals with ketosis prone to diabetes, but regardless of that, so it's an entity that we should be aware of, and those persons require follow-up in a hospital environment. So as a reminder, I'd certainly like to wish our friends happy World Diabetes Day on the 14th of November. And as we seek, as part of this Global Diabetes Summit, to share the information around the world, and also to embrace the knowledge from doctors around the continents, as we improve global access to diabetes care. So as a reminder, this quote from Frederick Banting is so poignant that he sold the rights to the University of Toronto for his street food soap in 1922 for $1 so that it was available to everyone. Insulin does not belong to me, it belongs to the world. And imagine in 2021, we are speaking about persons still having issues accessing this life-saving drug. So we're focusing on good habits, diets rich in fruits, vegetables, nuts, pulses, peas and beans, low fat, low salt, and low sugar. So we're moving away from the white rice, white sugar, white flour. We know that these ultra-processed foods are affecting our bodies, our minds, our spirits. So we're getting rid of bad habits. So including the diets rich in saturated fat, sugar, and salt. And to the bottom left hand of the screen, that is a local street food so popular in Trinidad and Tobago, similar to the chana bhatura in India, and it is referred to as doubles. So those fried flour parts known as baras, and the chickpeas or chana with different sauces and hot peppers that are local to Trinidad and Tobago. And in closing, I think a quote from Shakespeare would also be relevant to any talk on diabetes. In Julius Caesar, men at some point are masters of their fate. Our fall today, Brutus, is not in our stars, but in ourselves, for we are underlings. These are my references. On that note, thank you very much. God bless. Namaskar.
Dr. Joel, thanks very much for the talk. HbA1c demonstrated inadequate predictive accuracy in the diagnosis of diabetes mellitus. There is no consensus on the suitable cutoff point of HbA1c for the diagnosis. So how do we put HbA1c report for our better use?
Certainly, the hemoglobin A1c remains a useful tool in monitoring blood sugar levels in someone who would be a diabetic. However, in parts of the West Indies and indeed around the world, it's fraught with problems in those patients with hemoglobinopathies, anemia, or chronic kidney disease. So, and the lack of standardization among labs throughout the resource-poor countries would also affect its utility as a tool in the diagnosis. Many of these individuals would be better served to have, perhaps, if they have the osmotic symptoms of hyperglycemia and a random blood sugar level which exceeds 200, or even using the oral glucose tolerance test. Still, although it may be cumbersome in some environments, many patients actually ask about it. So as an annual screen for diabetes, especially if they've had it done, that it gives you an idea in terms of those postprandial hyperglycemia. So the hemoglobin A1c is useful. So if you find that it's elevated, of course, it should be repeated on another occasion, a few weeks apart, in order to confirm the diagnosis. But its utility in the diagnosis of diabetes is certainly a bit dodgy, especially in our settings with a lack of standardization and many other confounding factors that would hamper results. So I would say still that fasting levels exceeding 126, the glucose tolerance test, those individuals with osmotic symptoms and levels exceeding 200 would be clues. Certainly if the hemoglobin A1c is extremely elevated in settings of symptoms of metabolic decompensation, you wouldn't need a repeat investigation. Sometimes we send to different labs because of a lack of standardization. In persons, of course, so as an aside, if you are a diabetic with chronic kidney disease, you may want to consider monitoring blood sugar levels with another marker called fructosamine.
Thanks for the answer, sir. The second question is, with healthcare moving from the curative to the preventive healthcare, does the guidelines cover the aspect of community screening for the early diagnosis of the diabetes mellitus?
Beautiful question. As the watchword for the management of all patients with the metabolic syndrome is prevention. And we should be focusing, especially in places like the West Indies and India, in which we have such a high genetic predisposition. We should be focusing on screening at a very early age. And in fact, we are seeing now even school children have type 2 diabetes. So persons who have a family history, so if you're West Indian, if you're Southeast Asian, so if you have obesity, polycystic ovaries, those with fatty livers, we have spoken about women with a history of gestational diabetes. So if you have at least one risk factor, start screening from the age of 30. And our guidelines, according to CARFA, actually reflect this. And persons, the individual clinician, as part of the beauty and art of medicine, may want to consider screening earlier, especially in those persons who may have signs and symptoms or have multiple risk factors. So if I could reiterate at this point, genetics would represent a loaded gun, and lifestyle is pulling that trigger in so many young individuals now. So we're no longer seeing persons with type 1 diabetes in childhood or in the teenage years. We're seeing so many persons with rising weight, acanthosis nigricans, polycystic ovaries, and type 2 diabetes in childhood.
Thanks for the answer, sir. As we know, smoking and alcohol are one of the major risk factors for the diabetes mellitus. Is there any mention about the cutoff or the limit of smoking and alcohol consumption when it comes to the guidelines?
Smoking is the single most important preventable cause of premature death globally. And no amount of smoking is safe in somebody with diabetes. In fact, it has been said that if you have high blood sugars, one cigarette is equivalent to smoking 3. So we know that there is an increased risk for heart attacks, strokes, lung problems, and cancers associated with cigarette smoking. When we talk about alcohol, some individuals actually find that different alcoholic drinks may help blood sugar, and we know that you must be careful about the risk for hypoglycemia, especially if you're not eating with different drinks. The high alcohol content, and you may find that there is an associated low blood sugar and even hypoglycemic episodes. However, certain drinks are sweeter than others. In the Caribbean, a lot of individuals drink rum, and that is a byproduct of sugarcane. They may be mixed, so cocktails, mixed alcoholic drinks, and these also are associated with blood sugar spikes. Red wine, some are sweeter than others, and these also will be contributing to a deterioration in glycemic control. So 1 to 2 drinks for males is often recommended, and 1 drink or less in females, because we have been finding that that whole idea of moderate alcohol consumption is a matter of opinion, because in terms of the deleterious effects and the consequences associated with alcohol use, you may find that although there may be benefits accrued in terms of the cardiovascular system, the disadvantages may be greater than the benefits. So have a chat with your doctor. I think it would be a personal choice at that point as to how much alcohol is safe. But most of the recommendations would say perhaps 1 to 2 drinks in men and 1 drink or less in women, 1 drink or fewer in women.
Thanks for the answer, sir.
One of the greatest global challenges, it's a chronic illness, and it's a lifelong disease. However, it remains the goal of physicians to guide our patients through these peaks and troughs in their lives. And it's an honor and a privilege to be a part of this Global Diabetes Summit. God bless and namaskar.
With this, we end this webinar, and thank you all for your patient hearing. And thanks once again, Dr. Kalra and Dr. Joel.
Thank you so much to Dr. Nitin and our 2 speakers, Dr. Joel and Dr. Kalra, for your time and efforts you took to share your thoughts and experiences with the Doc Plexus community on this occasion of World Diabetes Day. A big thank you to our dear audience for their kind listening. Hoping this session will give you new insights in the treatment of diabetes. So stay tuned for our upcoming session on expert roundtable discussion on the latest developments in the field of diabetes. tomorrow 5 p.m. onwards. I will see you all again. And until then, stay safe, stay updated, and take care. Happy dog flexing.